Yep. He's on now. There we go. There's Dan.
All right. Well, if you guys are ready, why don't we get this started? My name is David Finney. I'm one of the partners and co-founders of LeapOrbit. And we're really excited to be here today with our friends from Moxie Health to talk about the CMS interoperability and patient access final rule. Looks like we've got a pretty broad audience of folks from health plans, folks from state Medicaid agencies, and then also folks from the technology community. So excited about hopefully a really interesting discussion. Julian, next slide.
Yeah.
So, we're really hoping that this will be not a traditional webinar. We don't want to do a whole lot of presenting. We're going to do just a quick overview of what the rule is and the key components. We're going to talk a little bit about the technology requirements that sit behind the various mandates. And then we're going to open it up to sort of bring any question, bring any issue you're working through. Tell us how your organization is approaching compliance with the rule. I would say at any point, if you'd like to join the discussion, feel free to drop some questions in the chat and we'll try to address them as we go. If you'd like to be unmuted and talk with us and share what you're working on or ask questions that way, that would be great too. And just let us know through the chat and we'll unmute you. Next slide. So a quick around the horn on our presenters today. Again, my name is David Finney. I'm one of the co-founders of LeapOrbit. For the last 15 years or so, I've been involved with health information exchanges and interoperability projects across the country. I've worked with HIEs from my home state of Maryland, DC, to the West Coast, California, Alaska. I've also worked with the Office of the National Coordinator with SHEIC, the HIE Trade Association. And I took a 2-year hiatus from my work in interoperability. My wife and I went to Southern Africa and worked on the HIV epidemic as Peace Corps volunteers. So Mrinal, I'll let you introduce yourself next.
Thanks, David. Welcome, everybody. Mrinal Bhaskar, I'm the other partner and co-founder at LeapOrbit. I've spent the last 20 years in healthcare interoperability domain, bringing about a dozen products and solutions to market. I was a co-founder at Health Unity, at Right Care Solutions, was founding principal at Audacious Inquiry, and looking forward to this discussion. Thank you.
Great. And then, yeah, Dan Wilson, founder, CEO at Moxie. So I've been working in the healthcare IT space for the last 15 years or so. Spent a number of years at Epic where I was engaged in deploying medical record systems, and then ultimately left to start Moxie, where we focus on clinical data exchange to health plans to support a variety of payment and operations use cases. So for the last 6 years or so, we've been deeply involved in doing bi-directional clinical data exchange between plans and health systems to support things like risk adjustment and quality programs, payment integrity use cases, basically anywhere that you would need supplemental data, clinical data, medical records, we've been doing electronically. And so when the Cures requirements came out, it's certainly been an area of focus and interest for us as we look at taking what was really historically a very EMR vendor by EMR vendor specific workflow and trying to figure out whether the regulation is going to create more efficient opportunities. So, and Julian?
Yeah, I'm Vice President of Business Development here at Moxie, focused on payers and partners we work with. Previously was at a medical record startup, Canvas, that I co-founded. And before that, worked at ACO models and kind of different regulations at the CMS Innovation Center, and kind of saw the need for better data exchange to facilitate the next generation of value-based payment models. And before that was in the consulting world. So yeah, I'll hand it back to David and the Leap Orbit folks to go through a few slides here. Excited for the conversation today.
Thanks, Julian. So, from this audience, I think most of this will be familiar to you. The CMS has issued the final interoperability and patient access rule in March, pursuant to authorities that were granted to it in the 21st Century Cures Act. The intention, the goal, the objective of these rules is to accelerate interoperability and patient access. And this rule really is about the liberation of patient data, using CMS's authority to push plans to implement new technology standards. The deadlines associated with this regulation have moved. CMS announced enforcement discretion after the rule was made final, in light of the COVID public health emergency. So you can see in the enumeration of the various requirements that there's been sort of a 6-month reprieve on the most imminent requirements. There are 5 kind of key expectations of the rule. One is to make available a patient access FHIR API. This is something that the Moxie folks are going to talk a little bit about. The second is a FHIR provider directory or network API. This is something that Leap Orbit has been working on really hard for the last year or so. And then payer-to-payer data exchange, meaning when a member leaves one plan and goes to another, the ability for that member to request that their records be moved from the old plan to the new one. And then requirements around improving the experience of duals, and an ADT event notification requirement that goes into effect May 1st. So this is obviously a lot, and it's a lot at a time when health plans in the healthcare industry are already dealing with almost an unprecedented amount of a lot. And so, not surprised if, this is a little bit how you feel when you kind of take stock of where your organization is with all this rules. It's kind of like, oh my gosh, this is just one more thing piled on a huge pile of requirements that's about to topple over. Next slide. The good news is if you're feeling that way, if you take one thing away from this webinar, I can tell you you're not alone. EHI did a survey of you all and your peers over the holidays. And not surprisingly, in the health plan market, almost 90% of the folks that responded to the survey said, gosh, they would love more enforcement discretion. They'd love these deadlines to be pushed back. 3/4 or more say that their readiness to meet the requirements has been impacted by COVID. And then also, again, not surprisingly, 2/3 of folks are most concerned about the patient access requirements. Very clearly, these are the most complex requirements in the rule. The privacy and security implications are great. And, because this is mandated to be done with FHIR standards, and this type of interoperability is new for a lot of plans. This is a really big undertaking. So I'm gonna ask Julian and Dan to talk a little bit about how they're thinking about these parts of the rule, and folks feel free to chime in if you have questions or you wanna add something.
Yeah, thanks, David. Yeah, excited for the discussion here. And I'll make kind of our remarks pretty brief because I want to hear what y'all are thinking and kind of questions that have come up as you've been looking at the requirements and starting to prepare for that July 1 date. I'll talk just for a bit to make sure everyone's on the same page about the requirements and some key considerations for patient access and payer-to-payer. So patient access API, the idea is, I'm a member and I can access my clinical and administrative data via API. And it really is kind of, the idea is less that, I would access it necessarily through a plan sponsored app, and more that we are going to foster kind of a marketplace where, any app can just access this data and it's going to be in the standard format. So we're really going to create this marketplace where kind of may the best kind of app win, right? So I can use any app I want and they can read this data, and the apps can compete for kind of member engagement and user experience and things like that. At least I think that's philosophically the idea of this rule, is kind of opening up this marketplace. And so when you look at the required data that's available, there's kind of three categories. There's claims and encounter data. So that would be kind of, the provider I saw, the cost of that kind of stuff. Clinical data, which is kind of the scope of, US CDI or US Core Data for Interoperability V1. That's kind of, a set. It's not comprehensive data in the medical records. Like at Moxie, we do a lot of work in clinical data exchange. Typically, our connections get kind of US CDI and then some other stuff that's not in US CDI. But US CDI has a lot of the stuff that you kind of think of when you think of, clinical data, right? So certain types of notes, but also the structured data like problems, procedures, things like that. And then formulary data is in this kind of Da Vinci specification. I think overall with the technical side, it's all FHIR R4. So that's kind of I think when you look at this rule and kind of the sister ONC rule, which is kind of the one that applies more to provider groups, it's kind of moving towards this common FHIR standard. I think the hope is that more and more data exchange kind of becomes standardized, because to date, like a lot of it's been, hey, if you want to, get data from this particular provider organization, you got to kind of work with their custom specifications and the weird quirks. I mean, I think that's still going to be the case for a while. And that's part of why vendors like us exist, because, data is very messy. But the idea is we're going to kind of standardize it over time to this FHIR spec.
Hey, Julian.
Yeah.
Do you and Dan see the app, sort of the third-party app ecosystem lining up to take a place and have access to these APIs? And if so, do you have a hunch of sort of who's going to be early? I mean, I think as just John Q patient, health plan member, like I've got sort of Apple Health on my phone, but beyond that, these health apps are not something that I've spent a lot of time looking at.
Yeah, there certainly are. We've done some surveys with probably 20 to 30 of these digital health companies to get a sense of where they're at and how they're thinking about this rule. And I would say, while there's a spectrum, there's certainly like kind of two primary buckets. One would be groups who fully recognize where this is coming from and are steering into it and plan to aggressively try to differentiate on, as they think about how they engage users and patients. Like they're building features that are going to incorporate clinical data. They're building out, authorization to get access to medical records as part of their onboarding for members into the applications. A lot of those apps tend to be, I guess, anecdotally ones that are, maybe a little more mature. Like they kind of get the game, if you will. Number in like the disease space. So they've got, maybe they're doing oncology research and they know they can monetize the data to life science or somebody else who's sponsoring. And so they already have an understood business model around why they should get the data, in the first place. So there's that great group. They're going to come out day one. They're going to be ready to go. They've already built. We were talking to some groups who are already ready, to go and claim information blocking and make the allegations. They know what they're looking for. Relatively small group today. I think most people fall more into the, I've heard something about it and I'm looking into it, but I'm not entirely sure what it means yet for me. So I don't think that on day one, this is going to be like a deluge of people showing up. There's going to be like a group that you're going to have to be ready to service out at the get-go. And then I would expect more slow burn with a ramp coming, because as soon as people start to demonstrate that this is now like table stakes, everyone's going to have to fold it into their offering. And I don't think that's going to take a terribly long period of time to go from like point A to point B. It's just like the classic, no one really knows how it's going to get operationalized yet. So if people have a lot of extra resources, they're well financed and backed, this is getting this is getting like bandwidth. And if they're a group who is more reactive to the market because they can't invest ahead of it, they're kind of taking wait and see. That's kind of the anecdotal to date. But like one of the things that we're working on unrelated to all of this is trying to get our hands around, what applications exist out there, how they think about privacy today, so that when ultimately they do show up to the plans we're working with and want to get access to data, we have some kind of mechanism by which to manage and filter risk. So some of these groups are going to require a lot more diligence than others. And, where do you spend your time? So I do think getting hands around at least how you're going to operationalize the request to connect, what level of diligence is going to be performed, and what resources are going to be used to do that. I mean, this is all like completely not core to your business. So where do the resources come from to do this? Using the customer support angle where you've got members calling in. Well, those people are the right people to be talking to members, but they don't necessarily understand the technical API infrastructure. And so are you going to cross-train them? Are you going to spin up a new team? Are you going to outsource? I think I'd be very curious for people on the call. I'm sure this is an area that you've done a lot of kind of reflection, probably made some decisions. Would be curious how you're planning to do the customer support side of this.
Yeah, it's interesting. I think, I think there's a number of apps that I've talked to a lot of the kind of verticalized, the Livongo, Amada type, like we're a company that serves a particular disease space. And I think for a lot of those players, I'm kind of curious to see how it plays out, because they, I think, have a big, use for this type of data. And so I think as you said, Dan, like for some of those really well-backed entities, where they have a lot of financing and they're preparing for it, I think a lot of others are more reactive.
Yeah, we've got our first kind of question in the box. The question is, what is the feeling from payers regarding working with providers on EDI to streamline referrals, auths, pre-certs, notifying admission denials to expedite payment, which results in decreasing overhead expenses, resulting in affordable healthcare? I mean, I think that's what's driving all of this. So I would say that the early observation is that the cures compliance falls into the get compliant bucket, which is not super focused on strategic value to the organization, frankly. It's like, make sure you have an API. And then there's the kind of the next step is, and now how are we going to get business value out of it? And the business value that I would expect everyone to be shooting for is exactly what this question kind of identifies. There've been some, kind of a draft rule put out that was expressly looking at using these services to do authorizations and refer, more the authorizations side of things. The Biden administration withdrew that initially because it came out kind of late under the Trump administration. Likely I would think that gets republished. Maybe there's some tweaks to it, but that's certainly the direction this is going. I don't think version 1 of the cures rule, though, is necessarily going to be going deep enough to facilitate a lot of this. So I guess my candid advice would be, this is an initiative that involves business and it involves IT. And that if you remove the business requirements and design for purely on cost and compliance, it is likely that the platform that gets built doesn't end up yielding strategic value long-term that you're looking for. If instead you think about these business cases during the design of your FHIR server, during the design of how you're going to index data, how you're going to normalize the data, all of those pieces, then I think there's massive cost efficiencies to be wrung out. Particularly, I think where you're going to see it is there's not enough data in USCDI to really automate the risk adjustment process, but it can be incredibly informative for suspecting. So I would expect there to be a lot of ROI to be gleaned there. I think there is going to be enough data, though, for a lot of quality programs. So I would expect more automation of kind of your HEDIS stars score calculations. That should for sure happen. And then I think the off piece is certainly and payments. So being able to support prepayment audits, post-payment audits, is going to be a component for sure.
Yeah, let me go to talk through this next one. Just a few key questions that we're seeing, and I think you know, I'm curious to hear from others kind of what they're thinking in along these lines. So one thing that we're thinking about, and I've heard kind of different things from different health plans and even other vendors on this, is kind of on clinical data. They say, yeah, I'll share data that's maintained. And so I think initially when this rule came out, there was kind of this thought of like, well, payers have all sorts of data, right? And a lot of it's just these unstructured PDFs, right? Like you get a PDF for some prior auth, and do you really have to like transform that to FHIR and share it out? And isn't that going to be really hard to do? And you know, frankly, like a lot of the kind of NLP type tooling to do that is not, it's not at the level where you can transform it and be certain of like you've taken this PDF that's like unstructured and you've kind of applied NLP and then it's structured to share out. Like a lot of those tools are, and that technology I think is coming along and it's impressive, but like if you're going to share data with members, you got to kind of be 100% certain or near 100% that it's actually correct, right? And so a lot of the kind of tooling that's like, we're going to take this unstructured data and you know, use AI ML to, you know, kind of make it into FHIR. I just don't think that's at the level where you would share it out. And so I think more recently in talking to plans, you know, what I've heard, and I think CMS came out with some clarification on this, is a lot of the plans that we're talking to, they're a little more focused on the administrative side, and then the clinical data is like the stuff that's really well structured, and then over time we're going to kind of add more of the unstructured pieces to it. But I'd be curious to hear from folks, you know, the attendees here, just how are you thinking about this? Because I've heard everything from like, we're focusing on claims and counter data first, and we're going to try to do a little bit of clinical data, to like, no, we're going to totally try to transform all of the clinical data we have, including unstructured stuff, and share it out from day one. The other piece on the claims and counter data is just, I'm personally curious. I'm you know, kind of following from the sidelines some of the price transparency discussions, which is kind of a perennial topic in the policy world. And I think, you know, coming from CMS, it's something I'm interested in. Obviously, it's not as applicable to Medicare payments. It's more of like, you know, for commercial payments, right? I think there are plenty of health systems who probably don't want there to be transparency, because, you know, they're getting paid a lot from commercial payers, and that's kind of, they don't necessarily want it out that, you know, this commercial payer is paying them 300% of Medicare. But, you know, that data will be available through the API. And so I think there could be some apps that kind of, if you get enough data, you can then aggregate it and kind of have a map of, you know, what are the actual rates that are being paid and how does it compare to like Medicare pricing. You know, there is a price transparency rule where, you know, health systems providers have to kind of share their rates, but I'm curious to see, like, will that move the ball forward on price transparency, or will it be more of this, like, you have to share claims and counter data and then you can kind of suss out the prices from that. And then the third thing is just really around third-party access. As Dan said, we're doing some work on this. I think it's, you know, you don't have a lot of authority as a health plan to deny members access, which I think is probably, from a policy perspective, I think it's the right move, because, you know, the idea here again is to open up the marketplace of third-party apps. But what if it's an app that just, it's going to monetize your data in a way that you wouldn't be happy about as a member, or it's, the security is really bad? You know, and the rule has some things in place around like guiding members and kind of giving them, you know, apps can like attest to certain things, and you can, you know, like we're kind of implementing something where it's like, we're going to kind of, you know, have a rubric for apps. But I do wonder about that stuff. I'm excited about that. I think it's work that needs to be done, but at the same time, like, you know, I've agreed to 1,000 different data use agreements for my data when I'm like using different things on the internet, or when I'm connecting different services together, and I've like never read a terms of service, right? And so the idea that members are going to like pay attention when there's some notification that an app is insecure, I would hope they do, because it's health data and maybe they'll be a little more aware of it. But just historically, I think when you look at different apps, people generally just kind of click through any kind of warnings. So I'd be curious to hear how people are thinking about that too.
Yeah, Julian, this to me is one of the great sort of double-edged swords of this rule. On the one hand, the ability to let patients control the exchange of their data and potentially move it to any place that they choose is incredibly powerful. On the other hand, as soon as this happens, the data has been freed from HIPAA, right, and all the protections that come with HIPAA. Like, these third parties are not covered entities; they're not business associates, and the gate is kind of being the gate's being closed behind this data once it's out of the barn. And so I think it's sort of an ethical question. It's something that every plan is probably grappling with right now to figure out, how do you empower patients on the one hand, but protect them from all the risks that come along at the same time.
Absolutely. Maybe we can do this quick poll. Or no, we didn't. Never mind. That's just looking at something else. We have some polls that we may do if we have time. But let me talk about payer to payer real quick, which I think dovetails with patient access, just because when we've been talking to plans, generally the infrastructure that you need to have in place is kind of, if you can do patient access, payer to payer is kind of an add-on to that in a way, where the infrastructure kind of and requirements are going to be similar. It's a bit different in that you need to kind of share data with other plans and receive data. The technical standard is kind of a bit different in that it's more like up to payers' discretions. And there's this thing where it needs to remain in the original format, which is kind of interesting, right? Like, if you're receiving data from multiple plans, and those plans, hopefully it's just all kind of in this FHIR R4 spec and it's compliant with that. That's kind of my expectation, but there is this provision where you have to retain it in the original format. So if it's not kind of, up to snuff with the FHIR R4 spec, you kind of have to maintain that in some way. So that's I think a complexity when you're thinking about the cures infrastructure you need to build that we're kind of accounting for in our offering. And I think other vendors probably are as well. The scope is the same. It's just clinical data, so not administrative data. I think what's interesting here is, we are very curious kind of to see, I think it could be something like when you sign up for a health plan, there's some kind of like, automatic kind of thing where health plans try to enroll members in payer-to-payer data exchange to get data, because I think there's a big benefit for plans of getting this historical data. And in a way, it could become kind of like a table stakes thing. Like, if you're a plan and you're not.
Yeah, Julian, I go so far as to say if you're not, it's a mistake, right? Like, this is an ability to instantly size up the risk of a new member. So if you couldn't do underwriting, but you can get access to their historic information, I mean, you should absolutely be doing that. And you can bet your competitors will be doing it to you. And so I think that has to be factored in. And it should be informative for all of the other programs you need to run. You're going to save because you're going to be able to close out quality gaps before you do a record retrieval and, do a whole analysis of it. You can identify where, gaps exist with a higher degree of accuracy and inform a whole bunch of different interventions. So I would go so far as to say critical in the Medicare Advantage space, but frankly, critical across the board.
Yeah,
I think in the managed Medicare space too. I mean, really basic questions like, who was this member's prior primary care doctor, right? Like, just continuity of care issues that typically are fumbled now because of a lack of data transfer.
Yeah, I think that's absolutely right. Like, if you're not doing this, the other plans will be. So it kind of becomes it's like a competitive disadvantage if you're not kind of acquiring data from other plans.
Yeah, there's a couple of questions in the Q&A bucket, which if you want to talk live, just raise your hand and we'll take you off mute so you can ask the question live. But just to kind of call it out. So there was a question regarding healthcare price transparency and claims encounter leading to universal healthcare or single payer system. And I got to tell you, I could nerd out with you on this one for like the next 12 hours. So, hold on. But without going too far off the deep end, I don't necessarily see any of this stuff tracking to any kind of single payer compression on, number of people out in the market. So I see that as kind of a different matter entirely. I do think that price transparency today is not really a thing, and even when we put out some requirements that people publish prices, like it isn't very accurate. It's very hard to use as a consumer. Anyone who's tried to shop around for this stuff knows we have a long way to go. I see this as kind of pushing us down a path, right? Like we have to get more data available, but there's no obligation to share claims with pricing data broadly, and like that type of stuff we're not going to get to the level where you could kind of like hack in and kind of ascertain exactly what pricing is based on the data that's being shared here. So getting to that level is not going to be super easy given current scope of the rules. I do think, though, this is all kind of informative of where the market is broadly going, which is access to data is long-term, not a strategic differentiator. It is table stakes. What you do with the data is going to become critical. And so using this as an exercise in building up the infrastructure to work with data at scale before your business is dependent on it entirely, I think is how I would frame it. Because the day is going to come pretty quickly where you will need to be able to use this data to generate insights that today you're not forced to work with at a scale that you don't need to operate on. So there is another question around value-based care and PCP attribution, and I do think that is critical in all of this. The rules themselves, though, are really focused on member and patient-based kind of requesting of data, right? As opposed to some of the more enterprise B2B use cases where you may say, for value-based care infrastructure, and you're going to want to be able to do real-time bi-directional exchange with the provider to, do care management or quality gap closure. That's like a byproduct, I think, of these rules. The infrastructure that is going to be laid to facilitate the patient-directed, member-directed exchange absolutely is the infrastructure to support the more B2B work. But there's a step in here that would be required that is going to complicate kind of wholesale use of this reg to run your like value-based care programs, if you will. But I think that this should absolutely lead to a more consistent experience getting data at a lower cost. It's going to change if like the hardest part in getting these programs set up today is getting provider buy-in around setting up electronic data feeds. This is going to bust that right open. And so, the dynamic of your discussions going out to providers and talking about wanting to set up, enterprise grade electronic interfaces is going to be different a year from now than it has been the last decade of trying. And that, I think, will have a big impact in how you think about contract design, execution of value-based arrangements, certainly thinking about attribution in a way that has a shared comprehension where, today this idea that providers are trying to ascertain attribution, you're maintaining attribution, and never the two shall meet, like that we have to do away with. There has to become kind of a common idea and understanding, but that goes beyond attribution into a whole slew of other areas. And I think it's in that idea that you can start to really see a future where there's massively lower administrative expense. So, I think that using attribution as like a starting point to say, let's get buy-in around having a shared source of truth between us and the providers, and let's use attribution as that place, makes an enormous amount of sense. And that is a foundation then to think about how you can do this in other areas. So, random thoughts.
No, I think it's interesting. I think we are, again, I think the payer-to-payer piece in particular, I think it will be really important competitively to do this well and to do it relatively quickly. I want to have time, make sure we have time for provider directory and some kind of open-ended discussion. So I'm just going to tee up a few things real quick and then hand it over to Leap Orbit to talk about provider directory a bit. But just to tee up some stuff, and maybe we can talk through this kind of in the time we have at the end. A few things we're thinking about is, one is member engagement. So, what are the opportunities for plan-owned sponsored apps, right? So again, the idea is not that you can't choose what apps members use, but I think a lot of plans we're talking to, they're trying to think of, maybe they have an app, right? That is kind of the plan app or like a partnered app. This is an opportunity to really drive members to that. And again, I think the good thing from a kind of overall healthcare perspective is, your app has to be useful, right? If it's a plan, otherwise, members may go to third-party apps, and they will go to other third-party apps anyway. But I think if you're not thinking about kind of planned-owned sponsored apps, that would be, a missed opportunity. The other one is around, and I'm just curious how are members going to use this, right? Particularly on the clinical data side, like, are they actually going to be getting their clinical data from plans? I hope they will be. I am, kind of awaiting how the market shakes out, because there's also the ONC rule, and that kind of comes to the second point here, where you got to get, you can get clinical data kind of more easily because of this rule from providers. And so you could see it playing out where, as a member, maybe I get some clinical data from my plan, but more so I'm getting it from, from other providers kind of via the ONC rule. And by the way, the spec is kind of the same, right? It's all this FHIR R4 data specification. The other thing, as Dan said, I think this is an opportunity to use this data for core plan use cases. So if you look at things like quality and risk adjustment, having longitudinal FHIR data that is kind of queryable and structured is useful for these use cases. And so if you have a FHIR server and you're not kind of using it for some of these internal things, I think that's a missed opportunity. Maybe it's not kind of what you do on day one, because the compliance date July 1 is coming up. But I think plans are thinking about this, and I think you want to be using it for these kind of core use cases to really level up how you're doing some of these things. Real quick, and then I'll hand it over to LeapOrbit on the sourcing approaches. I'd be curious if we have time to kind of hear from folks what they're seeing. We're seeing kind of different approaches, kind of from like, we're going to have one vendor to do everything, to like, we're going to take more of a best in breed point solution approach, to, I think with some of the larger plans, it's like, we're going to insource this with maybe a few kind of point solutions from vendors. I think they all have pluses and minuses. I think here at Mox and LeapOrbit, we kind of have like, LeapOrbit has done a lot of work on directory. We've done a lot on patient access. So we're kind of, I think, between these first two, but we do, I think part of what we're trying to do at Moxie is say to plans, we want to build something that you kind of maintain and own in a way so that you can use it for some of these strategic use cases. And with that, I'll hand it over to the LeapOrbit folks to talk a bit about directory.
Yeah, thanks. Thanks, Julian. So the provider directory requirement is actually sort of the one exception to the general rule here, that this regulation is about patient mediated exchange and patient access. The provider directory rule requires that the plan's full network be made available in a public endpoint that anybody could come and sort of access, download, ask questions against. And I think CMS's sort of objective here is a little bit different. It's maybe closer to some of the discussion around price transparency, right? I mean, I think everybody knows that provider data is just this perennial beast. Every plan throws a lot of manpower, sometimes a lot of money at it. And still, the outcome of all of that work is not very good. And I think one of the things that CMS also sees is that network adequacy rules sort of create a perverse incentive for plans to try to demonstrate the largest possible network. But a lot of times the way that happens is with dirty data or data that's hard to make sense of, and it leads patients who might be choosing a plan based on continuity of a PCP to have trouble making an informed decision. So CMS knows all of that, and I think they feel like a little bit of sunshine is going to be the best disinfectant here. Let's put all of these networks out there for public display. Let's let the technology industry figure out what they want to do with this information, and let's expose it in all of its glory to to members and to the rest of the market to try to put some pressure on plans to clean it up and find new ways to manage it. So that's really the sort of strategic thinking here. Next slide, Julian.
Hey, David.
Yeah.
I know we have some more slides, but at the risk of doing what we said we were not going to do, and focusing so much on slides, and this conversation has been great so far. But we do have Patrick Warfield with a question in the
Sure.
chat that wants to join in.
Sure, let's do it.
Do you want to do that first, or do you want to hit a few more here with the provider directory, or up to you?
Let me just take 2 minutes to make a couple of quick points, and then we'll open it up,
Okay.
if that's okay.
All right, yeah, we'll go to Patrick first, and I know that he has a conversation around patients and members getting access and creating buy-in. We've hit on that a bit, but I think there's a little bit more to unpack there.
Sure, yeah, for sure.
And then I'll encourage anyone else who has a similar topic to post it in the chat. So.
Okay. So I just wanted to draw a parallel to a comment that Dan made earlier, which is, if you are designing and building to check a box with these rules, you may find yourself sort of down the road with a solution that isn't flexible, and it's not extensible, and it's not able to sort of move where the market's going. So the provider directory requirement right now is focused on practitioners, so individual providers, and what it says is you've got to expose an API that will return a practitioner, the practitioner type, their specialty, their address, their phone number, and that's essentially it. Plus also a bulk endpoint where someone could request essentially a download of your entire network file. The CMS rules point to this Da Vinci implementation guide. And I've kind of circled in the middle of this slide just the 2 pieces that are relevant to the interoperability rule. There's a whole lot else in the FHIR sort of construct of providers and networks that aren't addressed right now. But in our view, this is kind of the opening salvo from CMS, and we expect that they're going to continue to expand on the rulemaking and ask that plans make more sort of sophisticated representations of their networks available via FHIR to essentially the public, anybody who might want to have access to it. Next slide. Keep going, Julian, actually. There is one other rule that's important for Medicaid and CHIP plans that's sort of interlocking and ties together with the interoperability rule. So for folks that are part of that, part of the market, I assume this is on your radar. Next slide. It's the 2020 MMC final rule, which creates some new obligations for plans to make a mobile-enabled provider search function available online. And then there are a bunch of additional sort of attributes of each provider that have to be available beyond what's just in the interoperability rule. So I'll stop talking in a sec. On the next slide, Mrinal, maybe you can just say a couple words about how we're thinking about this and sort of the options that we see plans thinking about between sort of the skinny FHIR compliance solution and maybe something that's more strategic and could serve the plan better in the long run.
Sure. Thanks, David. Yeah, so to hit on that point quickly, if you see this diagram, from the right-hand side, you see what we call the reference data, and really thinking about every plan, every organization, also provider organizations, they are keeping directories of provider information on their end, and it's quite wasteful to do this at every plan and every institution. And there's a need in the market for folks that are doing it at scale, at a national scale, and bringing that reference data to the table, so you can focus more on your specific data set and marrying that with the reference data. So this is what at Leap Orbit we do with our provider directory solution. We bring the reference data set to you where we are, bringing data from, many data sources, public and private, and collating, mastering, and then curating that data set so you don't have to. And because we do it at scale, we can do it very cheaply. And when you combine that data with your private data set, your own plan data, what have you, you combine those two and you have a very robust set of information that's validated and curated to make available to your members, but also developers that are trying to use that data set. So all through Fire 4.0 APIs. So really thinking strategically here, instead of doing all of that curation on your end, you could use a reference data set like the one Leap Orbit makes available. But our platform is also a master data management platform, so you can upload your own data, and we have a website available right now if you wanted to go test it out. You can upload your own data set and we will master your data set. If you have multiple provider data sets, we can combine those and master them, and augment your data with our reference data. And I'll stop there. Go ahead, Dave.
Yeah, I'm curious to see on provider directory one. I mean, I think there's kind of the age-old problem where provider directories are just like inaccurate, right? So, and that's been an issue for a long time. Like some of the studies I've seen about how plans have, a large portion of the data is out of date. And so, yeah, I'd be curious how you're thinking about that. Like, are you?
Yeah. Hey guys, I think, that's definitely a topical question, Julian, but because we have so many attendees on the call and we have 2 outstanding questions and we're coming to an end here, I think I want to redirect.
Yeah, for sure.
So I just added Patrick to the line. So Patrick, can we hear you, Patrick?
I can hear you.
All right, we can hear you too. Awesome.
Okay, great.
Patrick, we spoke a bit on LinkedIn, but I thought you had a great question. And just before you ask, I have some time that will go over the 1 o'clock endpoint. So if anyone wants to stick around and continue this conversation, I'm going to keep the webinar open probably till about 1:15, maybe past that, depending on how things go. I know it's Friday, folks might have a little more flexibility. So apologies for some of the slides. It was a lot of great information. This is our first one, by the way. And I think we're learning, and I would like to make this more of a regular thing. So I don't know if the panelists are open to that too, but if there are other folks on this webinar who want to be a panelist in the future, please reach out to me on LinkedIn. I'll drop my information in the chat. So Patrick, off to you.
Thank you. Hi, everybody. Thank you for having all of us get together for this topic. So my question is to do with member or patient buy-in. How do you get members to become interested in order to use a third-party app like Apple Health or any of the others, in particular, in light of the fact that the third-party apps are not HIPAA compliant and there are inherent security risks and so forth?
Yeah, it's a great question. If I had the answer, I would sell it to you. But the reality is, give them something of value. I think so when I was at Epic, we were trying to roll out the patient portal pretty aggressively. It had been around for maybe 4 or 5 years already. This was it was released in 1999, and adoption was like sub 10%, like way below 10%, for a very long time. And so there was a huge concerted effort, and it honestly didn't really work outside of, it was like the scheduling feature they really wanted. If providers didn't activate the scheduling feature, no one used it. Or it was the messaging their doc feature. But if it was like just getting my information, very, very low utilization. And so I think the key is, what is the value you're delivering? If it's like a patient population who's highly activated and engaged, it's, the chronic conditions, it's rare diseases, like those groups are highly engaged. If you give them something of value, they will be there. But if we're talking like the young invincible crowd, you're talking, general FYI apps, I think it's extraordinarily challenging to get people to buy in. But and when I say give them something of value, I don't think it's like the inducement of, $50 to fill out an HSA or something like that. Like that's a thing, I suppose. But if you're talking about sustained investment in their health and engaging and caring about, taking more ownership, I think it has to be something of more sustained value. So I apologize, it's not like a really like a tight answer, because I think it is highly dependent on the person and the kind of situation they find themselves in. I do think that, health plans have obviously been trying for many years with different services to do member engagement with really generally bad results. I don't know that these digital health apps are going to have any better success, other than the fact that they're very focused. They're not trying to be necessarily something to all people, and they take a more kind of consumer angle to things. So I do think there is value in probably identifying some specific applications that you think are going to add value to your population, sponsoring them, keeping them in the fold, trying to get your members to rely first and foremost on a service that you feel is good and is not going to be, doing some nefarious things with their data, and trying to kind of, to some extent, direct members into those services makes a lot of sense.
And Dan, just to add, I would say some of these developer-focused regulations will reduce friction in the market from a data movement perspective, and it will open some new doors. Because at the end of the day, if it were really easy for me to collect data from all my doctors and payers quickly using my iPhone, I'm, there's high likelihood that I might try that, right? And so I think how that removal of friction will be pushing us in the right direction.
One other interesting aspect to Patrick's question is what is the role of caregivers, especially in the Medicare Advantage market? So we're working with a Medicare Advantage plan right now that has a very high acuity specialized population. And they're trying to grapple with these rules for a member base that's probably pretty unlikely to ever use these apps, but potentially, children of their member base that would be highly motivated. So they're kind of looking around at a sort of a narrower set of apps that are focused on elder care and engaging with caregivers.
Great. Patrick, do you think we got to your question a bit? Do you feel like we answered it? Do you have any more to add?
No, I think that was great. Thank you.
Cool. Hey, Morgan, we spoke a little bit before everyone got on. Oh, you can already unmute yourself. Great.
I can.
I see you added a question. This is interesting.
Yeah, I did. So as we're looking at actually mapping all of our data sets for both the provider directory as well as the patient access API, APIs, plural, we have actually two different FHIR repositories. And so they have actually different implementation guides. And there are data elements we're required to present in these APIs that are not part of the standard FHIR endpoints. And so we're having to essentially make up what we think those FHIR endpoints should look like for those missing pieces that are required. And I suspect that pretty much everyone else is also making them up, which kind of takes away the idea that it's a standard. So I'm kind of curious to hear what your experience has been around those missing endpoints that are necessary to actually be able to deliver on these rules.
For sure. The good old like Z segment problem, like reimagined for FHIR. So
Yeah.
Yeah, no, I think you're dead on. I mean, like this idea of strict profiling and what Da Vinci and others are trying to do, I think is a big step in the right direction towards solving this problem. But it's lagging, right? It's lagging the market. And if it lags the market, which standards always do, then people implement things that are not standard. And I think it's a question of, do they get reworked later once standards come out and they get reprofiled or something like that, or do they not? And so I guess my thought would be, what you're doing, I agree, is going to be what happens. Now, I hate saying this, like I'm in the camp of kill as many middlemen as you can, right? Like we have too many in healthcare. The standards were created by consultants, though. They didn't work themselves out of jobs. There's going to still be transformation that is happening here, unfortunately. I would just make sure you're designing this in a way where you can reprofile and redeploy endpoints as soon as the standards mature to the point where you can, do that. And so decoupling some of the API exposure from the underlying server, I think is just super important to think through from an architecting perspective. But it is certainly a problem.
Yeah, Dan, exactly what I was going to say, which is keep your integration layers flexible so you can do mapping and orchestration easily.
Great, thank you.
Yeah, so, sorry, that was like a very unsatisfying answer to your question, but you're not alone, I guess. Which, actually, I'm curious as a follow-up, what data elements are you finding? So like if the rule is really tied to US CDI version 1 at the moment, is it on the administrative side of the world that you're running into challenges, or is it on the clinical, or what type of data are you finding falls outside of spec?
It's more on the clinical claims side than on the provider directory side, but there are a couple of things on the directory side. I would actually love to have a conversation, but I've got to pop over to my 1 o'clock meeting.
Yeah,
so.
No, absolutely. I appreciate the thoughts. The last thing I'd leave you with is Google has actually done a fair amount of mapping of admin data to R4 as part of, there's some work groups doing that today. I'll dig up a link and make sure we get it across to you in case you haven't seen it yet. But
Well, thanks. We're working with Google, so we're good.
We
there.
are, okay.
Yeah,
Cool.
we are. Thanks.
Yeah.
All right. Have a great afternoon.
You as well. Take care. I actually have to drop as well, but as Jake said, the chat will, or the line will remain open. I appreciate everyone's time today, and if it's not clear, we love this topic. So happy to take any questions related or only pseudo related as follow up. Thank you.
Thanks, Dan.
Yeah.
Okay. It doesn't look like we have any other questions in the chat right now. Does anyone have a burning desire to share or jump on? This would be a good time. I know we actually pushed a meeting back a little bit just a minute ago. So the Leap Orbit team has a few minutes. Julian, you can stick around. So one thing, unless anybody has punched in a chat, one question that I have that I've seen floating around LinkedIn is why would you do anything other than checking the box by wrapping your data with a file server? What's the benefit of working with reference data or working with a team like Moxie? So I don't know. Mernal, do you want to start with that, and then?
Sure. I'll take the reference data question on the provider directory side, and as I said in my presentation, when you think about the repetitive work that happens across the spectrum of care around managing provider data, and even if you think about how providers themselves have to update their data in so many different places, state boards, you got the NPES data, which over time sort of decays, and all of that, and none of that data is well maintained over time. And you think about that repeated effort, that is wasteful, and a lot of that data, think about contact information and direct email addresses and other things like that are very helpful for care coordination, are not aren't kept up to date. It's good to if you have companies like ours that are mastering that data, curating that data on an ongoing basis, and there's an efficiency of scale argument there. If one company can do it at a scale, can make it available to everybody for use at relatively cheap prices. In addition to that, as I said, we have a platform where you can marry your private data with the reference data that we have. So it's a master data management platform where we match your local data with our reference data. So those two things combined, it's quite helpful in managing your provider data.
Yeah, I would say on the patient access payer-to-payer side, I do think there's this with payer-to-payer in particular. As Dan and I spoke about, like if you're not getting that data, other plans will be. So it kind of becomes like having access to USCDI becomes more of like table stakes, and then it's more of a question of like, what data do you get beyond USCDI? So for things like risk adjustment, we found that the USCDI spec, isn't typically enough to do kind of everything you'd want from a risk adjustment workflow perspective. And so it's kind of like, okay, you got to go beyond the data that you might be getting from other plans, or you might get in kind of the USCDI v1 scope. But there's also just, using the FHIR API, like I think about, all the kind of risk adjustment and quality coding solutions out there, or the things plans have built. I think using that and making sure you're integrating with the FHIR data and getting this longitudinal record, it seems to me like that could be a big place to actually get kind of business value from this, aside from just like viewing it as we got to spend a lot of money so we're compliant. Actually being able to boost performance on, I think from my perspective, like quality care management and risk adjustment are probably the two biggest buckets that plans are looking at.
Yeah, Julian, I think that's the key question across both provider data and the patient access is, are you building a resource that's going to be able to be leveraged in the future to support other business processes, right? I mean, clearly there are a lot of administrative processes that require clean provider data. But if you're just sort of putting a thin wrapper on what you've already got and it's off on an island, it's not going to be useful to those processes in the future. And I think the same is true with the patient FHIR data.
Absolutely.
Okay. Looks like we don't have any other questions rolling in right now. So I feel like we covered a lot, and I think, I'd like to have another one of these if everyone is interested. Before we go, I know, thanks to the Moxie team, Julian and Dan, for joining us today. And David and Mernal, the co-founders of Leap. I thought everyone did a great job. So thanks again for everyone coming out. And if you'd like to reach out to us, you can either do that via LinkedIn, Leap Orbit, or Moxie Health, I think it is, Julian.
Yeah, moxiehealth.com. Yeah,
cool. And leaporbit.com. So we're here if you have any other questions. Happy to be a resource. And hopefully we'll see everyone on the next one.
Thanks, everyone.
Thanks.
All right, take care, everybody.
Take care.